From Microbe TB, this is Infectious Disease Puscast, episode 84, recorded on Monday, July 7th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. How are things going with you, Daniel?
You know, it's been busy, Sara, because I'm multitasking, right? I'm during my 2-week block being on service at Columbia, but I'm still trying to make it out. Well, still making it out to the hospitals on Long Island. So a couple weekends in a row, you know. So this most recent, I was here.
It's July in the hospital. Lots of excited new folks. I hope it's going smoothly for everyone who's on service.
Yeah, no, that's what I love this time of the year when you've got the brand new, fresh, straight out of medical school or just getting on the wards as a medical student. And, and sometimes you see, Sara, this is the best. So I have a couple people that I'm working with who a year ago were just becoming second years, a year ago, just starting out of medical school. And, it's just great. Great to see that.
It's a great time of year. Welcome everyone to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
Did I throw you off, Sara? I moved the banter up in front of that whole intro section.
I was something feels different, but you would think after this many episodes, I would have realized what felt different.
Yeah, I thought let's just get into the banter instead of so. All right, we'll see. People can write in and say, "Oh my gosh, you changed the theme music."
I can't believe you changed it. Yeah.
All right, Viral. Remember to listen to This Week in Virology, where it seems like those folks are getting a little political, fired up. They're just defending science is all that's going on. But we have the article, Clinical Outcomes and Perspectives of People with Human Immunodeficiency Virus Type 1, 12 months after initiation of long-acting cabotegravir and rilpivirine in an observational real-world U.S. study, Beyond. What do you think of that? Beyond. All right.
That's pretty good.
Okay. Published in Open Forum Infectious Disease. These are the month 12 results from the ongoing Beyond trial. Beyond is this ongoing 2-year multi-center, prospective, observational, real-world studies of adults who initiated the CAB and RPV, right? So the cabotegravir and rilpivirine, long-acting in the U.S. Key outcomes included reasons for initiating, virological outcomes, adherence, patient-reported outcomes related to treatment satisfaction, treatment challenges. So they've got 308 participants, median age 45. 87% are male, right? So we do have 17% female, 39 identified as Black. Now, those who initiated this long-acting treatment, most commonly were doing this because of treatment fatigue, adherence anxiety with the daily oral therapy and or convenience. And of participants with baseline viral load data, 97% had a viral load of less than 50 copies per ml for their most recent test reported at month 12. Mean treatment satisfaction scores increased significantly from baseline to month 12. This seems to be the number. 97% of participants preferred long-acting versus oral treatment at month 12. Proportions of patients reporting always or often experiencing challenges related to HIV treatment, fear of disclosure, adherence anxiety, reminder of HIV-1 status, and feeling stigmatized decreased from baseline to month 12. So, it's really great stuff. Most people are like, this is so much better. I don't have to take it every single day like this. Take this pill. Remember, you've got HIV and everything else. So, great stuff there. All right. And the article, Healthcare Provider Knowledge of West Nile Virus Diagnostic Testing in the United States 2022, was published in Open Forum Infectious Disease. And it looks like providers need a refresher here. They used a survey of 1,502 U.S. healthcare providers and found that about 1/4 ordered the correct lab tests. As in 75% got it wrong. Oh my gosh. Come on, guys. West Nile virus IgM antibody on serum using an ELISA in patients with immunocompromising conditions that may delay or prevent development of IgM antibodies. Go ahead with that West Nile virus PCR. In patients with neurological symptoms, CSF IgM and immunocompromised, virus PCR testing in addition to serum testing, and then confirmatory plaque reduction neutralization tests can be performed and is recommended for severe or atypical cases. No role for IgG testing when making a diagnosis of acute West Nile virus infection, right? I mean, you can get it before, and then the IgM turns positive, you got it again, and we certainly saw that.
A quarter, though.
I should share this story, Sarah. So I, claim to fame, right? In addition to claiming I invented the hard drive, which just upsets my children. When I was practicing out in Colorado, I made the diagnosis of West Nile virus. It was the first case in the state of Colorado, and I had to do it with the CDC and send samples to the CDC, and they ran that. It was very exciting. All right, moving into bacterial. Be sure to listen to This Week in Microbiology. The crew there is doing a good job. But I am going to start off with best article ever, Risk and Distribution of Metastatic Infections by Primary Infection Foci in Staphylococcus aureus Bacteremia. And I pasted in this figure. I mean, look at this figure, and hopefully folks that are, this is pretty. Stop listening. Got to watch this one on YouTube because you got to see this figure, or you can just go click on it later. But it's this wonderful figure because I always make this distinction when I'm discussing, or particularly when I'm on the wards talking about it. So there's some way that Staph aureus gets into the system, but then you end up often with a primary focus. And then what we're worried about is secondary or metastatic spread, right? And I think it's important to sort of think of it this way because here you have this wonderful figure where you can see, okay, here's the primary foci, and then what percent of the time does it end up in different metastatic sites?
It's a very satisfying.
Are you as excited?
Graph. Yes. Well, I was looking up because this type of graph has a specific name. It's I think it's alluvial or something. I was trying to look it up as you were talking, but I wasn't fast enough. But the flow. But anyways.
Well,
and,
I'll describe it while you look it up.
Huh? I wasn't quite fast enough. Next time.
But it is really cool. I mean, it's really, people got to look at it. One is it's visually stunning, right? I mean, it's beautiful. And really, it's almost like, the part on the right sort of sucking things in. I mean, all the different primary foci that might end up going to lung, which is a huge chunk, right, of metastatic foci. You also have a fair amount going to bone, and really kind of almost everywhere can go to joint, almost everywhere can go to bone, almost everywhere can go to lung or eye. Don't forget the eye. But really interesting to see sort of starting with where you are with, endocarditis maybe being an initial foci, but just all the showering events that could occur. Yeah. All right. A couple of articles here on C. diff. And first, the article, Clinical Management of, I'm just going to say C. diff. I'm not going to pronounce that big, long word. C. diff infection with fecal microbiota transplantation, a real-world cohort study published in eClinical Medicine. Investigators conducted a multi-site cohort study, included 1,170 patients with CDI, I'm even making it shorter, C. diff infection, treated with fecal microbiota transplantation. That must be the way the Brits spell feces, right? Fecal with the F.
Yeah, got out that extra A.
Just throw it in there. Through capsules, colonoscopy, or nasojejunal tube, right? You want to get it all the way down there into the jejunum. Primary outcome was cure 8 weeks after treatment. They investigated antibiotic pretreatment type and length. The FMT, fecal microbiota transplantation dosing, administration, post-FMT prophylactic vancomycin. And so let's break this down. So They've got 1,170 patients that received 1,643 FMT treatments, median age 71. Following their first FMT treatment, 60% were cured. If they just kept doing it after repeated FMT treatments, up to 81% cured. Prolonged antibiotic pretreatment up that cure rate with an odds ratio of 1.2, so extra 20% bump. So prolonged antibiotic pretreatment. Now, FMT administration through oral multi-dose capsules, 69%. Colonoscopy, 69%. So in patients for whom FMT was initially unsuccessful, repeated FMT was more effective than antibiotic treatment alone. Doesn't necessarily matter how you get the treatment in there, but it does look like you're going to really move things in the right direction with prolonged antibiotic pretreatment. All right, now we've got the article, Clinician Management Preferences for C. diff Infection in Adults, a 2024 Emerging Infections Network survey published in OFID. Sort of interesting, clinician management preferences. What about following the guidelines? Well, in 2021, the IDSA, Infectious Disease Society of America, Society for Healthcare Epidemiology of America, SHIA, introduced new recommendations for managing initial and recurrent C. diff infection. They do this electronic survey to distribute it to members of the IDSA Emerging Infections Network, targeting ID physicians and healthcare professionals in the U.S. who manage adults with C. diff infection. And the survey assessed treatment preferences, clinical practices, and barriers to assessing and prescribing CDI therapies. So I thought, why don't we start by actually reviewing what are those recommendations, and then we can figure out what people are doing and not doing them. So these are the abridged recommendations, because, people aren't going to listen to this like all day, but we'll, give us 15 minutes, we'll give you the world. And here's going to be the world of CDI guidelines. In patients with the initial CDI episode, should fidaxomicin be used rather than vancomycin? Well, what do they say? For patients with an initial CDI, we suggest using fidaxomicin rather than a standard course of vancomycin. Conditional recommendation, moderate certainty of evidence, and they have a comment. This recommendation places a high value in the beneficial effects and safety of fidaxomicin, but its implementation depends upon available resources. Vancomycin remains an acceptable alternative, tone added by me. In patients with a current CDI episode, should fidaxomicin be used rather than vancomycin in the recommendation? In patients with recurrent CDI, again, we suggest fidaxomicin rather than a standard course of vanco. And again, comment, this is low certainty evidence, vanco in a tapered and pulsed regimen, or vanco as a standard course, are acceptable alternatives. For patients with multiple recurrences, vanco in a tapered and pulsed regimen, vanco followed by rifaximin and fecal microbiota transplantation are options in addition to fidaxomicin. In patients with a CDI episode, should bezlotoxumab be used as a co-intervention? Well, recommendations in patients with recurrent CDI episode within the last 6 months, we suggest using bezlotoxumab as a co-intervention along with standard of care antibiotics rather than standard of care antibiotics alone. Whole big long comment here, including comments about warning from the FDA in patients with a history of CHF. Bezlotoxumab should be reserved for use when the benefit outweighs the risk. Now, what did our article find relative to these wonderful guidelines, which basically are saying go ahead and use, fidaxomicin and not vanco? They found that significant barriers, including high costs, insurance challenges, and limited availability of the CDI therapies were impacting clinical decision-making and folks adhering to these guideline recommendations.
I have a lot of familiar names on that paper. It's some of my colleagues. Yeah,
cronies, some of your cronies, Sarah.
Yeah, well, I think everyone knows, like, depending on the patient's insurance, like whether or not you can get fidaxomicin seems to depend a bit on the patient and where you are. And I was just thinking how sad I am that bezlotuximab is not really. I think we've either used our last dose or came very close. I requested using one of the few doses we had left on a patient not too long ago. So unfortunately, that won't be a great option.
Yeah, I was finding, Sarah, it's almost more of an issue like trying to do some of this stuff in the hospital, right? I mean, at least the insurance companies are sometimes a little more reasonable than grumble.
Well, I didn't intentionally leave you hanging to do all of the beginning. I realized no, I guess I didn't pull a viral paper. This next one I got from OFID, donor-derived tuberculosis, and 3 solid organ transplant recipients from the same donor. This shows my bias because I think this is interesting, so I'm sharing it. So they had 3 cases of donor-derived TB and recipients. So there was 2 kidney recipients and 1 liver from the same donor. So as like a quick bullet, so the first patient was a kidney transplant recipient who actually had a history of LTBI that was treated, got their new kidney and induction with alemtuzumab, and developed this inflammatory mass at the renal hilum, and ultimately was diagnosed after an allograft nephrectomy a couple weeks post-transplant. The second case was miliary lung nodules. That was a presentation. And then the third patient had also like a rim-enhancing fluid collection at the right adjacent to the transplant kidney. And then the donor was someone who was relatively young, I think under 40, and was born in a TB endemic area but had no known past medical history. So the good news is that all the recipients were treated successfully, but clearly had significant morbidity. That first patient had their allograft taken out. And then they, of course, had prolonged hospital stays, some sort of drug side effects, adverse effects. And so I thought, this is quite interesting and just a good reminder that donor-derived TB is possible, to think about it with unexplained fever and solid organ transplant recipients. But I think one thing that's useful to think about is donor-derived tuberculosis versus reactivation TB in someone who receives a transplant, and how that time to presentation is likely going to be very different. So these cases were pretty quick after transplant, within like a month or 2, but somewhere in that window of 2 to 3 months after transplant is when we would think more about donor-derived TB versus someone having reactivation. That probably is something that's happening, a year out, 14 plus-ish months after their transplant. And the other thing that's interesting here is that both of the kidney recipients had sort of allograft involvement or allograft adjacent disease, which makes sense if you think about the route of acquisition versus someone who has previously inhaled TB. So the other thing that I thought was cool at the end, they had short little patient perspectives that they included, which I thought was quite nice.
All right. Just want to briefly mention septic arthritis and osteomyelitis in finger caused by Mycoplasma phocimorsis from Brown Bear, Alaska, USA. Published in EIS in September 2024, a 29-year-old hunter sought care 7 days after he lacerated his left fifth finger while skinning a brown bear on the Alaskan peninsula near Ivanhoe Bay, Alaska. The injury occurred when separating paw bones to free skin. His hand and knife contacted the bear's mouth before injury. On day 53 of illness, tissue from surgery sent to the University of Washington Molecular Micro Lab for broad range 16S ribosomal DNA PCR revealed this Mycoplasma species. I thought this was really funny. They conclude clinicians should use doxycycline or moxifloxacin therapy in treatment refractory cases when exposure to seals, cats, or bears while awaiting molecular diagnostic results. What do you think about that last?
I'm looking forward to when I can pull that out on rounds. Actually, let's add doxy because it was a seal bite.
Yeah.
And then this next one was an MMWR. Foodborne botulism outbreak after consumption of home canned cactus nopales, Fresno County, California, June 2024. So the report shares an outbreak of 8 cases caused by contaminated home prepared prickly pear cactus nopales about a year ago. And as a reminder, botulism is a rare and potentially fatal illness caused by, for the adult version, ingesting food with the neurotoxin produced by Clostridium botulinum or other neurotoxigenic Clostridium species. And so the bacteria can set up shop and grow in improperly prepared or stored food items, particularly home canned or sort of home preserved veggies. And so if that food is low acid, unrefrigerated, or has an anaerobic environment that's sort of conducive to these. And I learned that this cactus, I guess, was a relatively low acidity thing to be canning. And so proper canning requires sterilization of jars both when empty and after being filled with food with a pressure canner, rather than what ended up happening in this case, which is sort of dipping empty jars in boiling water before putting in whatever food item. So 10 patients were hospitalized, 6 required ICU care, 2 patients required mechanical ventilation, and patients had hospital stays ranging from 2 to 42 days. Incredibly, all the patients did get timely treatment. They all got antitoxin. They've all recovered. They actually included a photo, which I put here, of the cans, because basically it sounds like the nopales were brought to some sort of gathering at a picnic, food, whatever it was, party, and then sort of brought back to a party the next day where they were having leftovers. And so very interesting, good reminder for your summer potlucks. Yeah, and it's kind of I've only seen a couple cases, fortunately, so hopefully no one will run into it, but just in case.
All right. I like the photo. I think that's great.
Yeah. I feel like they don't usually include photos of their epi investigation, so I appreciated it.
All right. The article, 1-stage revision total hip arthroplasty for polymicrobial periprosthetic joint infection leads to high reinfection rates, a mean of 5-year follow-up, published in the journal Arthroplasty. I realize I got a couple of these joint infection papers this time. So one here in the bacterial section. So one's going to be in one of the other sections. So this study represents the largest study reporting the outcomes of 1-stage revision for polymicrobial PJI. Nearly 1 in 3 patients experienced septic failure at midterm follow-up, right? So 1 stage, 1/3 failed. Nearly 1 in 3 patients experienced septic failure at midterm follow-up. Now, looking at the ends here, not as many as we'd like. You know, they say this is the biggest ever, and I'm expecting huge numbers. 65 patients had positive cultures, isolating 2 or more distinct microorganisms. Most common organism was Staph epi. That was 69%. Most common polymicrobial component was Staph epi and Cutibacterium acnes. That was 13.8. Survivorship from all-cause revision was 79.7%, while survivorship free from septic failure was 66.9. There were 17 septic failures with a mean time to failure of 1.8 years. All right, most of which, 92.3%, isolated the same organism as the initial 1-stage revision.
All right, and then
that's pretty long, actually, right?
Yeah.
You know, so.
Well, I was just on our sort of ortho ID oriented service and had to refresh a lot of my ortho ID / ask for lots of help and people to double check that I'm doing the right thing, because I don't see as much of that on a daily basis.
No, it's interesting. I think when you get into practice, there's certain like little niches that you get into. Like one of my partners, Yira Patel, she's the neurosurgeons always call her. I mean, part of it is because she shows the hospital like 5:45 in the morning is when they want like the ID consultation, and those people show up at 7. Oh my gosh, like that's just way too late. Or Sachi Shah is the one who does a lot of these joints over at one of the hospitals, so they do a lot of joint replacements. And you see, you sort of end up with your niches to some degree, and it's kind of nice because you become maybe within the world of ID even better at sort of a particular part of it.
Yeah. Well, my next one has to do with bones, but totally different scenario. This is from one of the Nature journals, I think Ecology and Evolution. It was entitled 4,000-year-old Mycobacterium lepromatosis genomes from Chile reveal long establishment of Hansen's disease in the Americas. So Hansen's disease or leprosy, we think of with Mycobacterium leprae, but there's also this more recently described M. lepromatosis. And so past infections have been identified in archaeological tissues as early as 5,000 years ago in Europe, Asia, and Oceania. And the authors here present 2 M. lepromatosis genomes that are about 4,000 years old, indicating a long and previously undocumented history of this infection in the Americas. And so they sampled 35 teeth and 19 bones with pathologic lesions from 41 individuals at 5 archaeologic sites representing various time periods. And then they talk a little bit about how it would also help us to understand susceptibility in rodents, armadillos, other animals, similar to how there's been some data about squirrel populations in Britain and Ireland that were non-human reservoirs for leprosy. So I did include, there's a photo of the location of the sites there on the pretty close to the coast, and even a picture of a bone chunk and a tooth chunk there. So I always think these kind of, I don't know what there's probably a name for the field of science it is where you look at microbes in like archaeology, paleontology sites. I'll have to look it up. I don't micro something.
Micropaleontology.
Yeah, something like that. Very cool. Yeah, very cool.
I like the pictures. Yeah, no, this seems like a lot more fun than some other jobs out there. All right. Fungal. Yeah, nothing to watch. You gotta binge the season at this point, season 2, and just keep fingers crossed for when will we hear about season 3. Actually, for one of my friend's kids, I bought him the actual video games, The Last of Us, which I claim at some point he's going to teach me how to play. But the article, good. Outcome Predictors of Candida Prosthetic Joint Infections, a Systematic Review and Meta-Analysis, was the editor's choice in Open Forum Infectious Disease. A systematic literature review was performed in PubMed, Medline, Embase, Web of Science up until July 2024. Articles, cohorts, case series, case reports reporting individual data of adult patients with CPJI, Candida prosthetic joint infections. Like everybody's got to have like these letter acronyms. Data about underlying conditions, characteristics of infection, outcome were collected. A total of 385 CPJI, I'm just going to say Candida prosthetic joint infections, including 204 hip, 152 knee infections. From 110 publications were included. A lot of work here. Polymicrobial infections accounted for a third of the cases. Candida albicans, 47.2, was the predominant species, followed by Candida parapsilosis. In multivariate analysis, independent predictors of failure were co-infection with Staph aureus, dropping down your success rate by 60%. Debridement retention of the prosthesis, right? Not getting it out of there, about a 75% drop in success. Whereas first-line therapy with amphotericin B was associated with a more than tripling of your likelihood of success. No difference according to the type of prosthesis exchange procedure, whether you did 1, 2, or 3 stage. Just basically, you got to get that infected biofilm contaminated thing out of there. Use of local antifungal therapy had no significant impact on outcome. So I was a bit surprised. I didn't see this coming, Sara, I will tell you. Probably not using as much amphotericin B as maybe this would suggest. So I looked a little bit in here, and apparently there is some literature, and they reference this as well, and mechanism on why this might be the case. So amphotericin B displays a better in vitro anti-biofilm activity compared to other antifungals, particularly the triazoles. Now, the echinocandins also display acceptable antibiofilm activity, but they did not find any benefit of its first-line use here in the Candida prosthetic joint infections. And that's actually similar to some other literature that they reference as well. So I don't know. I'm sort of thinking, like, if we get a Candida prosthetic joint infection, are we going to jump in there with amphotericin B based upon, well, a tripling of your success rate?
Maybe Alex to start.
All right. I guess I'll defer this to Dr. Sachi Shah, who's kind of our joint expert person. All right. Parasitic. Be sure to listen to This Week in Parasitism. Actually heading into the city this Friday. We're going to do a live recording with Chuck Knirsch is going to be there, and Vincent and Christina Nella, and really cool article we're talking about, like how parasites in the microbiome sort of impacts cognition. So
Nice.
Very cool. But only one lonely parasitic article this week. The article examining pricing and availability for neglected tropical disease therapies in the U.S., published in Open Forum Infectious Disease, retrospective analysis of prescription rates, wholesale acquisition costs, shortages conducted for 11 treatment products from 2019 to 2024. Aggregate all this stuff. While prices for most NTD diseases were stable, albendazole prices decreased by 78%. I was surprised by that. That's awesome. But albendazole prices rose by 60%. Miltefosine remained expensive at, what is this per treatment course? $48,000. Oh my gosh. They found that there are limited manufacturers of NTD drug treatments in the U.S., increasing vulnerability to shortages. It's a lot of money for that miltefosine.
That is a lot of money. Well, we'll round out with miscellaneous. This first one that I pulled was from OFID, 10 practical tips for a successful presentation at ID Clinical Case Conference. You know, like sometimes you read something, you're like, oh, I wish I had put that together. I thought that when I read this. So I really liked it. It's, focused on, thinking about how to do well at ID Case Conference, kind of the things that are unique about what we do in ID. I think it's a really great resource to hand out to new fellows at this time of year. A lot of things that you can kind of coach people on. And I won't go into each of the 10 tips. Folks can check it out, and there's a visual abstract. But I just want to give my usual reminder that I think strong case conferences are not always zebras or those crazy, unique, unusual cases, that actually talking about topics or things that we see a lot is very effective. And I do the same thing for febrile, that sometimes people ask, should they talk about this like one crazy thing that they saw a couple years ago? I said, actually, if you do something that's bread and butter, it makes it, gives more longevity. And I think people go back to it and refer to a lot. So I think this is a nice resource that people can save in their folder to share with others.
All right. The article, comparison of periodic in-person ID care to daily tele-ID care at a community hospital, published in Open Forum Infectious Disease. So here we have the results of a retrospective chart review comparing the outcomes of 100 patients seen via periodic in-person ID care from January 2019 to November 2019 versus 100 patients seen via daily tele-ID care provided through live audio-video telemedicine visits and electronic consults from May 2020 to August 2020. So really encouraging results. The daily tele-ID care had significantly higher Charleston Comorbidity Index scores, right? So these are sicker folks, but they ended up with shorter length of stay, were less likely to be discharged on IV antibiotics, 34% versus 51%, and had more frequent discharges on PO antibiotics, 39% versus 23%. It sort of connects there. No significant differences in rates of transfer to tertiary care facilities or in-hospital mortality. Now, I highlighted this. The 30-day readmission rate was higher for the daily tele-ID care group, so 11% versus 1%. However, only one readmission was ID related, and that was a C. diff infection. The diversity of ID diagnosis made between the periodic in-person ID care and daily tele-ID care were similar, except for increased rates of tick-borne illnesses diagnosed via daily tele-ID care. There was greater utilization of the daily tele-ID care compared to periodic in-person ID care. So sort of interesting. I'm wondering if that readmission rate is tied to the higher Charleston Comorbidity Index. Are these like sicker people? Are there things were going on? But really kind of encouraging for this model.
Yeah. And the last thing I pulled from the Lancet, evaluating the impact of 2 decades of USAID interventions and projecting the effects of defunding on mortality up to 2030, a retrospective impact evaluation and forecasting analysis. So this was as you can hear from the title, a comprehensive analysis trying to look at the impact of total USAID funding on mortality in low and middle income countries over the past 2 decades, and then they project the effects of the current and proposed funding cuts on child and all-age mortality through 2030. They estimated that the USAID funded programs that have so far helped prevent more than 91 million deaths globally, including 30 million deaths among children. The high levels of funding were associated with 15% reduction in all age and all cause mortality, a 65% reduction in mortality from HIV/AIDS, 51% reduction from malaria, and 50% reduction from neglected tropical diseases. And, of course, the paper discusses how the impact of funding is not just directly funding health programs or health interventions. The influence from all these is also related to just improving social determinants of health among poor populations. So supporting efforts for poverty alleviation and education and water and sanitation efforts. And so they project that funding cuts and the dismantling of USAID could result in over 14 million additional deaths by 2030, so in the next 5 years. So there have been various modeling papers out there. I know we haven't quite caught all of them on Puscast. We've tried to grab some of them, but this one sort of has a focus on USAID. And so just more for you to add and reference when you're hopefully advocating to policymakers about U.S. global health engagement. And so I thought I would just end with a little summary statement that they have in their brief implication summary. For many low-middle income countries, the resulting shock would be similar in scale to a global pandemic or a major armed conflict. Unlike those events, however, this crisis would stem from a conscious and avoidable policy choice. So,
wow.
Excellent. And I just, it just seemed like the right thing to end on. So that brings us to the end of this Puscast episode. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher, or YouTube, right, where you can actually see all this. And then make sure to subscribe, like us, ring the bell, and leave comments. We'd love to get your questions, comments, paper suggestions. Just keep sending them to puscast@microbe.tv. And if you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders, parasiteswithoutborders.com. Just click on that donate button.
I'm Sara Dong. You can find me on Blue Sky at Sara Wynn Dong, at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.